Hi, welcome to Functional Movement Systems and Research. My name is Stephanie Newbold. I'm a sports physical therapist in Evansville, Indiana. I work a lot in patient care, primarily with high school and collegiate athletes, but I use the functional movement systems in my day-to-day basis. I truly believe that this system has changed my practice on how I evaluate movement, assess how my patients are doing, and really making me a little bit more of a sharpshooter within the clinic and how I can truly make sure I'm hitting the main impairments that are kind of implicating and causing their movement dysfunctions. So FMS and functional movement systems has been around for about 25 years or so and very prevalent within our research. We've had a lot of research articles that have evaluated the FMS, the Y-Balance, SFMA, and truly what we started with was maybe more looking at functional movement and how to assess that, but truly it has evolved to assessing more than just movement based. We've truly tried to include more of lifestyle factors of how can we look at the person as a whole and truly evaluate all the different things that can maybe assess how they're moving and what injury predictions things we can look at to make sure we keep them moving well. So, Kyle, what I want you to start with is where do we first start? What does our past foundations look like?
Awesome. Well, thanks, Stephanie. This is really exciting for us to be able to talk about this topic. I mean, you can really kind of resonate the passion that Stephanie has for this and how she's been doing this for pretty much her whole career and using it as a guiding principle. And I think just taking this opportunity to for us to really kind of update you a little bit on the literature and the research because as Stephanie mentioned, I mean 25 years of has a long time for a particular screen and a test, and it's really compiled literally hundreds of research studies. So as we were kind of talking about the where we are currently and even the future, I think a good starting place is let's actually kind of review where we've been, and I want to talk about the past. So the functional movement screen was actually a solution to the overwhelming need for making a more meaningful and robust pre-participation sports physical. I mean, if you can think about, getting your sports physical, maybe back when you were in high school or 20, 25 years ago, I know when I got mine, it a lot of times was your height, your weight, hop up and down a few times, measure your heart rate, and then go play sports. And it just seemed like there was something missing. It felt like that the physical should be more robust and have a little bit more teeth to it. And I think that's really where the functional movement system came into play. Now, as time went on, as screen was established and utilized in this capacity, as you can imagine, people started to wonder, well, does this screen have any predictability? Does it actually predict folks that are more likely to get injured? And that's actually sparked a lot of interesting discussion because I think that as different research groups have looked at the ability of the FMS to predict injury or not, that's become a very kind of major topic, a talking point about injury prediction and prevention. And I think we just really, one of the goals of this webinar is to just confront that big elephant, if you will, and just like let's talk about what the functional movement screen can do, and let's also talk about maybe where the limitations are, and I think that would be just very meaningful for a lot of people to have that discussion. So the big elephant obviously surrounding the FMS is around injury prediction. Everyone, kind of looks at the FMS and says either it predicts injury or it doesn't. And if it doesn't predict injury, then maybe I'm not going to even implement it. Maybe I'm not going to use it. Maybe it's useless. And I don't think that's the case. That's not the intention. And that's certainly, I think, more of a narrow-minded approach to the utility of the FMS. But with that said, though, I think we're also to say that it has no value with injury prediction is also narrow minded because I think as we kind of explore the evolution of the research over the last couple decades, we definitely see that there is something there from an injury prediction standpoint. So really, one of the first studies that was ever done on the FMS was associated with Kyle Kiesel doing this study in NFL football players. And he found that if he screened athletes with the FMS and they had a cut point of less than 14, kind of that 14 out of 21 cut point that we hear so much about in the literature, but those folks that were less than 14, they were actually associated with 11-fold increased risk for an injury. And so that's meaningful, right? That was kind of the thing that set it all apart. And this 14, it wasn't just plucked out of thin air. This study was actually the first one that really established that, through a statistical process called a ROC curve. And that ROC curve is really used to maximize the sensitivity and the specificity of the screen. And really, that 14 is what came out. And just so happens that if people were less than 14, then on the FMS, then they were 11 times greater odds for an injury, which made people start to think, okay, well, maybe this screen is very predictive. But the caution is, though, as more and more research has come out over the years, I always like to use kind of the analogy of like the weather, right? And we do our best to try to predict the weather, and sometimes project out and forecast it out weeks in advance. And certainly there's a lot of different data points that go into making those decisions, not just one factor. And guess what, it changes by the minute. So sometimes when they predict that it's going to rain a few days in advance, it ends up not raining, and we're like, oh man, see, the predictive models are all wrong. It may not necessarily be the case that it's not useful. It's just that there's certainly linear change and variability that occurs. And that's what I think we see a lot with the FMS, because if we look at all the papers, literally the hundreds of papers that have been published on the functional movement screen, there's a couple things I want to point out. Number one, they all use the composite score, that 14 out of 21 composite score. And if you were to divide these papers up as these papers are supportive of the screen as a predictive entity, and the other half being that these are the ones that aren't predictive, that don't show any statistical relevance to predictability, it actually is about a 50-50 toss-up. Half the papers basically say that the FMS is predictive, and the other half say, no, it's not. And, as these smaller studies, have come out, over the years, it now gets to the point to where we can actually do higher level studies. We actually do systematic reviews and meta-analyses, because as you get more data and you get more subjects over time, we can actually now do higher level statistical tests. And so to date, there's been 6 systematic reviews and meta-analyses published on the functional movement screen. And it's basically the same thing. Half of them are supportive of the test from a predictability standpoint, and the other half say it's not published. It's not predictive of injury. So let's just wade into that, just a little bit. So what we know is one particular study that came out, and this was in 2015. It looked at the FMS, and it found an area under the curve of 0.58. Now, what is an area under the curve? It's a very advanced statistical test that really tells us about the utility of a screening test for making predictions. And, in general, we like that number to be more like 0.7. So as you can see here, the FMS definitely below that at 0.58. So we start thinking more of that coin flip situation, right? It's 50-50 shot if you're going to get injured or not. So very much in line with some of the other papers of, we 50% predictive, 50% not. But interestingly enough, another systematic review came out just the following year in 2016, and it actually reported a little bit more favorably to the functional movement screen. It showed that it has good reliability. That's really not a debatable metric. The reliability of FMS has always been moderate and better, especially if you have some training and you have some reps under your belt. But from the injury prediction standpoint, it actually used the composite score, 14 out of 21, and found that people that were less than 14 actually were 2.7 times greater risk for an injury. Now, that's not nothing, right? That's something there. Now, again, is it tenfold? Is it 50-fold? Well, no. But 2.7 is still a meaningful number if I can identify with one test someone's kind of injury risk. Now, as we've looked at these studies, we as I pointed out earlier, all of these systematic reviews are using that composite score, that 14 out of 21. And we know that has limitations, right? I mean, let's just play this out for just a moment. If I were going through the screen and I can score threes, on all the tests, except for, let's say I have pain when I do the deep squat. I get a 0 for the deep squat. I have threes on everything else. So I score an 18 out of 21 is basically how my score would get. If I follow kind of the conventional research to date, it would suggest that, well, I am not at risk for injury. I'm above 14. Therefore, I'm in good shape. And if I were to go down with injury at some point, then we would say, well, the FMS is ineffective and didn't work, right? The trouble with that is I already have pain. I have pain with movement. I have pain at 1 times body weight. And I just think about playing that out. If now all of a sudden I start squatting with load on my back, or starting to do a lot of volume with jumping and plyometric training, or even just going out for a run, which is, multiple times my body weight. If I have pain at body weight, the chances of that pain exacerbating into a significant injury or a major time loss event goes way up. So really, I kind of go back to, what is the purpose of the functional movement screen? Because yeah, injury prediction is cool. Everyone loves that. But that's not really the purpose. The purpose was, let's screen for major movement limitations and pain. And we define that as, a 1 on a movement pattern is a major movement limitation, and 0 means you have pain with something. So those are really the key variables that we're looking for on the FMS. The problem is, none of these systematic reviews and a large proportion of the cohort studies that are out there are not focusing on the individual scores. They're actually focusing on the composite score, which, like we said, has limitations. Now, interestingly enough, this study came out and actually found a little bit of support for what I'm saying here. They looked at Division II college athletes. They had a good sample size of about 84 of them, and ran them through the FMS, followed them out through the course of their season, and then we want to see, okay, did who got hurt, who didn't. And the interesting thing about this at the 1-year follow-up was that if we use the 14 composite score, then that was actually not associated with people having an injury or not. So again, not predictive, kind of in line with some of the other research. But what was very interesting is that if you said, regardless of composite score, let's take the composite score off the table and just look at people that had, 1s or asymmetries on the FMS, so those major movement limitations, and see how they did, with getting hurt or not, we actually found that people that had any 1 or asymmetry were 2.7 times greater risk for having an injury. And then again, that's regardless of their composite score. So almost very similar to that second systematic review that I cited, that, about a 2.5 to 2.7 times greater risk. Now, we've also looked at, in different studies, reading this particular study that looked at just, one-off, major movement limitations as being predictive. Like, here's the shoulder mobility screen of the FMS. And this is looking at in baseball players. And if you've got a 1 on your shoulder mobility screen, then that was actually associated with, a 5 times greater odds of having an overuse, injury or symptoms in the, during the preseason of baseball. So that limitation, that movement limitation, and then you start putting volume on top of that, tends to be important, right? And we may need to be aware of those type of things. The other big thing that the FMS screens for, not just the movement limitations, but it's the pain. And I think that pain with movement is such a significant risk factor. We see that study after study after study in multiple populations, that if you have pain at 1 times body weight with a simple movement pattern, the chances of that turn into a bigger injury down the road is just really goes up. And no different here in this particular study that looked at, if you had, no pain with movement, then you basically had even odds for getting hurt. You weren't at risk at all. But if you had pain with 1 movement, then that risk went up. If you had pain with 2 movements, hey, guess what? It went up. When you get to 3 or 4 movements that are painful, your risk again gets into that 2.5 times greater risk for having a more substantial lost time injury, and that's just looking at pain, right? So I think we've got to take in consideration kind of both those metrics, movement limitations, but also the pain. That's really the essence of what we're trying to get at with the functional movement screen. Now, we all know that using one test to try to predict all the injuries out there seems like a far-fetched crusade, right? And by no means is that the intention or the goal at all here. Like, truly, injury risk we know is multifactorial. We have to consider multiple risk factors. There will never be one test that's going to predict all injuries. There's too many factors to consider. And so a more comprehensive approach seems like that would be reasonable. So what I love about the study that Mike Lair did here is he took the functional movement screen and added in the lower quarter Y-Balance test, another just standalone, reliable, and valid test that's shown predictability, and said, well, what if we do both those tests? Well, instead of just doing the FMS by itself, let's do that plus the Y-Balance test, and also let's take into consideration, maybe have you been hurt before, and do you currently have pain, and we can now get at all those asymmetries as well as all those limitations on both the Y-Balance test and the FMS, and now we can actually create an algorithm, right, that we can weight pain, asymmetries, movement limitations, previous injury, and it creates a nice way for us to categorize people, essentially. And so what's nice about what this algorithm does is when you put it into the Move to Perform software here, it will actually categorize you into one of 4 distinct classifications. You're either substantial deficit, meaning that you have a lot of risk factors, you have pain, you have a lot of issues, or you're all the way down into like an optimal category, meaning that you're doing pretty well. You don't really have a whole lot of risk factors, and you're actually exceeding pretty well. And then you have the moderate and slight kind of in between there. But now you can kind of categorize folks. And so what Mike Lair did in his study was, he ran people through the FMS and the Y-Balance. Here's how they broke down as far as categorizing them using that algorithm. You see 26 people in substantial and 27 in optimal, and then several more in the between categories here. But what was very compelling to me is that he followed these folks out throughout their season and tracked who got hurt, who didn't. And look at how these statistics broke down. If you were in the substantial deficit category, 61% of those people ended up having a lost time injury, 30% in moderate, 16% if you were slight. And look, if you're optimal, you actually, nobody in that category had a significant lost time injury. So it really is very compelling data there that suggests that, man, if we can allocate people into a category, we may be able to make some decisions. Now, interestingly enough, like, I always like to think about screening as a way for resource allocation, right? Like, who needs the treatment, who needs the most help? Well, certainly I think we would all agree that substantial deficit and moderate deficit folks are really the folks that need the most resources and need the most attention. So in this particular study, he kind of, as a secondary analysis, he said, well, let's combine substantial and moderate together and call them just high risk. And that gives us a little bit more sample size, so a little bit more statistical power here to understand what's going on. And look what we found. People that were in the moderate or substantial deficit group had a relative risk of 3.4 times. That means they were 4.5 times more likely to go down with a non-contact injury if you were substantial or moderate risk. That's really powerful. But the key is, it's not just the FMS, it's FMS plus Y-Balance, plus injury history, plus pain with movement, right? It's actually our first look at combining multiple things together that really we hadn't looked at before. Now, we're living in, kind of this data-driven machine learning age. AI is here, and we'd be silly to think that, AI is not going to be driving a lot of the decisions and predictive models that we're going to be making in the future. But already, even as we're just now at the tip of the iceberg with AI, there's already been a high quality study that has included the functional movement screen as part of its AI machine learning model. And this was a very well done, robust study that had 480 athletes, multiple sports, multiple competition levels included. And the functional movement screen was just one of many factors, that were in this model. So 42 some factors, from performance metrics to psychological factors to more just biomechanical and kinesiological factors, but 42 some factors. And really, when you boil it all down and you use AI and the machine learning to really tease it all out, what do you find? The FMS was actually the number one predictor of performance among all those factors. It actually accounted for almost 14% of that predictive power in the model. And high FMS scores were actually associated with reduced injury risk and improved performance. So it's amazing to think that, okay, the FMS isn't nothing, right? There's something there, right? There's something there that it picks up on, that it tells us. Now, is it accounting for 50% or 60% or 80%? Well, no. But when used with all those other variables and factors, look what the model was able to do. And that really kind of gives us that recommendation, is that probably the FMS shouldn't be used as a standalone injury prediction screen. It's really, it doesn't have that power. I don't think any test has that power. But maybe putting it together with other things maybe has some merit. So I don't know, Stephanie, what do you think about that?
No, Kyle, that is great. I agree. The FMS alone, it is fantastic. It's a piece of the pie. But it's a puzzle piece. It's a puzzle piece of everything. Of if we didn't have that, that's not going to give us the whole picture. And I think that's really what that's boiling down to. Is yes, it's a piece of it. But what's more? What else is there added to this? And that kind of brings us what in our current research is. What we're looking at is what all different factors are going into our musculoskeletal health and evaluating those. And really, what the functional movement systems has gone to. So we've talked a lot about FMS. We've talked some about Y-Balance and how the collaboration of those come together. But as we start looking at this of trying to get whole pieces of the pie, we start adding in SFMA and FCS and Symmio of how can we now evaluate the entire person and evaluate parts of movement, but also how can we start incorporating lifestyle factors. So what that brings us is when Kyle Kiesel first did this research, he's assessing what different risk factors are for our musculoskeletal health. And like we've talked about a lot previously, we have our movement components of the FMS, pain with movement, SFMA, Y-Balance, but also other impairment-based measures such as maybe dorsiflexion or grip, static balance. But we can't forget, yes, we have those movement and parent base, but what about previous risk for injury, our historical factors, or other things such as our cardiovascular fitness, our BMI, or our perceived readiness or recovery? All these different things of kind of puzzle piecing all these different components together really gives us that whole picture of what influences our musculoskeletal health. And certainly that was just one study. And what we want to do next and look at is, does this apply to multiple people? So what Deidre Tahan did, she now looked at a bigger portion of people, evaluating those within the Army Rangers, and found very similar things of a smoking history, previous injury, or previous surgery, those impairments that we talked about of ankle dorsiflexion, or even movement and performance-based measures, all seem to play a factor into someone's musculoskeletal health. And certainly we don't want to just look at one study and give that's the information for all. Do we see a consistent theme throughout our literature that is directing us towards that multiple components are risk factors? And the answer is yes. Roan in his study, what he looked at was same thing of looking at female sex, BMI, prior injury. Those components were now a consistent theme that they were finding in this, the same thing with movement assessment and performance measures. And I think one really particular thing to look at within this study, and very, very interesting, is that when they did this study, they did it off of all service members. So going from your highest level, most elite, to all the way down to those who are even cooking in the kitchen. So that gives you a good spectrum of maybe our ordinary daily people who are living, to all of our elite athletes, that these all apply. No matter what your level of athleticism is, all these different factors are saying, hey, this is gonna, if you have these predisposing ones, or you're not moving well, or have pain with movement, you're going to be at an increased risk for an injury. And I feel like that's really powerful. A consistent, same thing, we see this down with Campbell. Different demographic, pain related, and movement based measures are all pointing to, hey, these are things that can put you at an increased risk for an upper quadrant musculoskeletal injury. And then another study, even broader of a military study, was done. Same thing, looking at gender, age, movement assessment. How do you cope? Now adding in different elements of your social support, coping, your mental health. All these components are pointing to our musculoskeletal health is not just one small piece of the pie. It's really looking at your movement-based factors, your lifestyle factors, and how do we look at all those as a component. Now, what these previous studies did is kind of looking at more of them in silos. So, what I want to think about is when you go to your doctor, you typically say you're going to your annual physical screening. Typically, they're going to be taking your blood pressure. That is kind of a accepted yearly annual thing that you do, unless you have other things going on. But what we do with this screen is they're going to assess your blood pressure. You get a reading. Say if your blood pressure is a little high that day, but you don't have any other factors, or haven't gained any weight, you haven't had a smoking history, your physician's probably not necessarily going to raise the alarm and put you on a ton of blood pressure medications. We're probably just going to have a discussion on how can I change maybe certain factors in order to get this under control. Or maybe this was just a one instance that I ran into my appointment because I was running late and my blood pressure is a little high from that. Now, it's a little bit different of a discussion that if my blood pressure is high that day, in addition to I have a smoking history and I've also gained 20 pounds and I'm not really that active, start adding on those different components. Then we're going to start having some more interventions and discussions, probably with my physician, of how can I maybe address my lifestyle factors, but maybe there's some medications I need to be on, or how can I start addressing these other components in order to mitigate or decrease my blood pressure, so that way I'm not at an increased risk for a cardiovascular event in the future. So I feel like that is a very accepted practice. Everyone kind of understands what that happens and how that happens on an annual basis. What I feel like is where our moving our future of our musculoskeletal health is, how can we get this now to assess from a musculoskeletal standpoint and even a movement-based standpoint? And that's what Dietrich Tahan did in here, of like looking at all of our musculoskeletal injuries and those risk factors that are involved with those. What does that look like when we start adding on multiple components together, multiple risk factors together? You see here just this chart of, if I have 0 risk factors, my likelihood of an injury is pretty mitigated. Kind of just that even odds of maybe I probably won't, maybe I will. But if I start adding on multiple risk factors together, if I start getting in 5, 6, 7, 8 risk factors, my likelihood of having a future injury is highly elevated. That is kind of the power of when we start adding on, similar to our cardiovascular screening. If I have multiple risk factors, same thing with musculoskeletal health. If I have multiple factors that are compounding, my risk of musculoskeletal health goes very high. So as we add in through the research, we found that we have the silos. We identified impairments that elevate our musculoskeletal health. We now know when we compound multiple risk factors together, those elevate our risk for an injury tenfold, and really make that something that we need to look at and assess. Typically, this is done with a lot of people who maybe are already injured. And when we go through a rehabilitation process, we look at all these different factors. But what I thought was really interesting with this study is that these are all military personnel who have been injured and are now returning to full duty. What they found with this study, that when they still return to full duty, 44% of those individuals still had pain with one movement pattern on the SFMA top tier. That placed these individuals at a 1.5 times fold increase of greater odds for a future injury. Let alone how I mentioned earlier of how our movement and our injury and our musculoskeletal health is multifactorial. Remember, I talked about the mental health component or psychological readiness. When these military members returned to full duty, 25% of them thought that they were returning not fully feeling 100% mission ready. Now let that sink in. 25% didn't feel like they were ready. 44% of them still had pain with movement. What we need to kind of start challenging ourselves with is how can we be better to mitigate risk moving forward, even from someone that has been injured. Now, another thought process to think of is looking at, in this study, they looked at active duty Army soldiers. So those who are already in active duty, maybe had a previous injury, maybe didn't, but 59% of those that were currently in active duty reported pain with at least one movement. So we have individuals who are participating in their work activities as an active duty member, and they have pain. Where do we start within our musculoskeletal health? How do we start evaluating this? We're really good at capturing those individuals who have maybe been through injury, maybe need to do a little bit better job of mitigating and pain after once we return them to work. But how do we catch those who are currently working and experiencing pain? How do we mitigate those impairments that they may be currently experiencing? And that's where we think of efficiency. How can we assess more people the most we can in the little amount of time that we can? Now, we've talked earlier in this webinar a lot about the functional movement screen, and that screen typically takes maybe about 10 minutes to complete. Now, within these last two research articles that I discussed, they're using the SFMA, so selective movement assessment, and typically that takes maybe 2 minutes to complete. Think about how many more people we can screen if maybe we're utilizing a shorter screen such as the SFMA, that it's still very valuable. It is a way to indicate pain with movement, which we know that pain with movement is a risk for a future musculoskeletal injury. Maybe we can find different ways to be more efficient, so that way we can assess more people and get them the help that they need. And that's really where we start to move of what does our current practice look like? We know all these things, and we found silos within the silos of risk that increase our risk of future musculoskeletal health. We know that compounding factors add to that and elevate our risk for an injury if we have multiple risk factors. We know that some individuals are maybe being discharged with still current pain, or we even have people out there who have pain but haven't sought any healthcare providers. So, Kyle, what are your thoughts of where do you feel like the future is moving based on all these things that we're finding in the literature?
Yeah, Steph, that's great. You said something very powerful there where, we're trying to be more efficient but sometimes there are people that have real insurance limitations. They're being discharged with risk factors, with pain, and maybe it is a financial factor, or maybe maybe it is a competency factor from rehabilitation. But regardless, these folks still need to be on top of their, musculoskeletal health and still kind of working on maintaining that as well as maximizing that. So, as we move into the future, I always start to kind of wonder as we take this on a little bit of, well, what do other health professions do in this regard? And, I think about what our primary care physicians and, other folks that are non-rehabilitation professionals do, for their patients. And I think about nowadays, I mean, you can go to any kind of pharmacy store, and pick up an automated, blood pressure cuff that you can measure your blood pressure accurately at home. Same thing with your blood sugar with a glucometer. You can track those things. And when COVID-19 was at its height, I mean, self screens with COVID screens were very common. So I just think about, like, all right, self screening and self monitoring, and the patient almost being able to do this on their own without the professional, without waiting for an appointment, or as their kind of first pass at seeing, do I have issues that I need to go and get checked up, or am I okay? And I think the self screens really resonate to me, and I think that's where I've seen the literature move with movement. With movement is how can we create a self screen? And what's interesting is it helps really get people in the door sooner if they need it. Right? I mean, can imagine a day when all your patients could come and get help before they had that ACL tear, before they had low back pain, before they had surgery. Right? Like you would just love that as a clinician, being able to see people before they're having major pain or major injury, and work on risk factors and work on tweaking their programming, and hopefully a lot of those people never have that major injury because of that. Right? That would be a phenomenal day. Right? And where we've kind of moved a little bit is starting to go down the path of the Symmio application. I know you mentioned the Symmio application a little bit earlier, but this is an app-based program. You can use it on a phone or a tablet. And what's great about it is it's got video guided instruction, and that the patient can really just follow along with several different movement patterns, and it'll help score them. Is it kind of pass fail, or do they have pain? So the scoring is very simplistic and user friendly, not as kind of comprehensive as sometimes an FMS screen or an SFMA top tier can be, right? But these are very straightforward pass fail markers that they can hit. And in this particular study, looking at it, we kind of looked at the reliability and the validity of it, and really patients that were just off the street, folks that participated in this study, they didn't have any medical training, they've never been exposed or trained on the app before. They just came in and we handed them the tablet and said, okay, follow the instructions, we're not going to say a thing. And they screened themselves. And now we had someone in the background, a movement specialist, screening them at the same time. They didn't talk to each other, but lo and behold, they found very similar results. It was a very reliable process. If the patient just followed along with the video guided instructions, they got the same results as an expert. Also, what we found was that if you did poorly on these movement tests in Symmio, there was actual good correlation to some of the mobility focused tests in the FMS, as well as the Y-Balance test performance. So some of the more established legacy tests that we know have that predictive validity to some degree backing behind it, the Symmio was able to detect a little bit of that too, as a self-screen that's ran by just an individual and not a healthcare provider, which is very interesting and actually really exciting when you think about it. It really, I think, just flips the script a little bit. It kind of empowers patients, right? And I think that's really what's great about it is, instead of always having to passively rely on, I got to call my doctor, I got to call my therapist, I got to get in and get checked out and get their opinion and evaluated. This actually creates a little bit more of that patient centered philosophy, where the patient now can screen themselves and then make a judgment call based off, yeah, I feel like based off how I'm moving, I need to go and get checked out. Or no, I think I'm doing pretty well. It's giving me some suggestions on some exercise to do. I'm going to start there. And if I don't make progress, I can always call my physician. I can always call my therapist then. So it puts it back with the patient. So I really think it just, using the Symmio app, it does three things, right? It provides that patient the next best step, right? It's going to give recommendations so they can get in if they need to get in, to really, again, allocate those resources appropriately. It also provides good education on movement quality. I mean, again, movement quality is important. I think no one would disagree that people need to, have good movement quality. We need to consider that. So, but I think a lot of times patients don't know what that means. Like, what is good movement quality, and when is it bad movement quality, right? And this really helps kind of set that up and give them that awareness. It also empowers the patient to come see a good rehabilitation provider, or their physician, before they have that catastrophic, in some cases, career altering, life altering injury or setback that we know can occur as those risk factors build up. Just like you said, you start getting 6, 7, 8 risk factors that start to build up. It's almost a guarantee you're going to go down with an injury. And man, wouldn't it be nice if we could clip a few of those off the table and keep you in that lower risk bucket for sure. So, I think about Symmio, and I know in that particular research study we did, we just focused on the movement piece of Symmio, but that's not just Symmio. Symmio is actually a bigger animal than that, and it should be, because when I think of wellness and overall health, it's not just movement, right? I mean, there's a lot of other factors, a lot of other domains that kind of factor into someone's overall wellness, right?
Absolutely, 100%. And that's truly what Gray Cook is talking about in these papers is how can we love and are good at looking at movement-based symptoms, but like you mentioned, we need to be evaluating their lifestyle factors as well and self-care factors. And that's what a component of Symmio brings. Of now we're looking at behavioral health, we're looking at nutritional awareness, we're looking at sleep quality, we're looking at overall activity. All of these different factors play into someone's musculoskeletal health and truly is the future of musculoskeletal health, too, because we're now assessing and giving the ability for the patient or the individual to assess for themselves and help maybe mitigate those risks before becoming injured or before needing to see a physician or physical therapist or occupational therapist or any healthcare provider. And what Symmio does, in addition to maybe they get them in the door to see us, and now it's our job as healthcare providers to manage all these risk factors. And how does that look in rehabilitation? So now we're using a collaboration of all these different screens and surveys to now assess movement and lifestyle. But one big thing of when we have all of these movement and lifestyle factors is we need to make sure we're not adding risk onto their already current factors. We need to make sure we're assessing those appropriately so that way we can either help get them referred out to the appropriate healthcare professionals or help give them different management tools to help mitigate those risk factors of truly so that way now we can mitigate those, whether that's if someone is only sleeping 3 to 4 hours a week or not eating well or not hydrating themselves. All those things can help basically not be able to get to what we need to do here in the clinic. So if those are too high level of bigger, broader things, they're going to impact what we can do from a musculoskeletal standpoint. So if we can help mitigate those, we can do our jobs better and help resolve those current episodes that they're currently experiencing. Now, one thing before we do discharge those patients is we really need to make sure we're rescreening and resurveying to make sure we're mitigating as many risks as possible. And if they still have a few risks left, we need to make sure we're educating the patient on what current risks remain. So that way they can continue to work on those themselves at home or with another healthcare provider. So that way they can get back to the daily activities or the goals that they want to get to. So we obviously discussed a lot within this webinar. What I want to do is a quick review of kind of hitting the main points within this webinar that we discuss. So FMS is not consistently predictive alone. It is one piece of the puzzle, and like we've talked about, there is multiple domains that we need to be looking at in order to evaluate someone's musculoskeletal health and injury risk. One thing that we can help minimize this or make it more patient accessible is through Symmio of self screens. How can we get the patient now to do self screens at home so that way we're evaluating musculoskeletal risk factors before they become a problem or before they start experiencing pain? And that's what we can do with Symmio and technology is now making it more accessible. If they're not able to reach a healthcare provider in time, they can now do this on a daily basis in order to mitigate those risks and make sure they're still continuing to participate in the things that they want to participate in.